This is Shehzad Ahmed presenting the third video in the series of ECG lectures. In this video, we will discuss the formation of normal QRS complex as well as the right and left ventricular hypertrophy and the right and left bundle branch block. The normal width of QRS complex is less than 120 milliseconds or less than 3 small boxes. A widened QRS complex may indicate a left or right bundle branch block, and the amplitude of QRS complex is altered by left or right ventricular mass, and it can indicate right or left ventricular hypertrophy. All of these conditions will be discussed later in this video. Here we will discuss the formation of a normal QRS complex due to depolarization of the ventricles. In the initial phase of depolarization of the ventricles, the first part to depolarize is the right side of interventricular septum. So the initial depolarization vector is directed rightward in frontal plane and anteriorly in horizontal plane. So all the leads, particularly the bipolar limb leads whose positive pole is pointing leftwards, for example lead 1 and lead 2, and those unipolar limb leads which are located toward the left of the heart, for example lead AVL as well as AVF, will record an initial negative deflection during this portion of depolarization of the ventricles, and lead AVR, which is located toward the right side of the heart, will record an initial positive deflection during this portion of depolarization of the ventricles. Similarly, in the horizontal plane, the leads located anteriorly on the chest wall, for example lead V1 and V2, will record a positive deflection, and leads located more laterally, for example lead V5 and V6, will record an initial negative deflection during this portion of depolarization of the ventricles. Later on, when the left ventricle starts depolarizing, in this mid to late phase of ventricular depolarization, the depolarization vector is directed leftwards and posteriorly. So now the changes will reverse. The leads 1, 2, AVL and AVF, which were initially recording the negative deflection, will now record a positive deflection. Similar will be the case with leads V5 and V6, and the lead AVR as well as lead V1 and V2, which were initially recording a positive deflection, will now record a negative deflection during this portion of depolarization of the ventricles. Now we will discuss the criteria for right ventricular hypertrophy. RVH or right ventricular hypertrophy is diagnosed when R wave in V1 is more than 7 mm in amplitude, or if there is coexisting right bundle branch block, then R wave with amplitude more than 15 mm will indicate right ventricular hypertrophy. The other criteria are R to S ratio in lead V1 more than 1 if R is more than 5 mm, and R to S ratio in V6 less than 1, and S in V5 or V6 more than 7 mm in depth. Shown here is the ECG of right ventricular hypertrophy. You can see that in lead V1 the R wave spans almost 11 mm, and there is prominent almost 7 mm depth S wave in lead V6, as well as there are associated ST segment depression and T wave inversion in lead V1 to V4, also termed as right ventricular strain pattern. Here also you can see by seeing the leads lead 1 and lead 3 that there is right axis deviation. Several criteria are available for the diagnosis of left ventricular hypertrophy. Skollo-Leon criteria is the most commonly used criteria, and in this criteria we combine the amplitude of S wave in V1 as well as the amplitude of R wave in V5, and if the sum is more than 35 mm, then it is termed as left ventricular hypertrophy. The other criteria is R wave in lead AVL. If it is more than 11 mm, it also indicates left ventricular hypertrophy. Coronal voltage criteria have also been proposed for diagnosing left ventricular hypertrophy, and these combine the amplitude of S wave in V3 and the amplitude of R wave in lead AVL. And if the sum is more than 28 mm in men or more than 20 mm in women, then it is termed as left ventricular hypertrophy. Shown here the ECG of a patient with probable left ventricular hypertrophy. Here you can see that if we combine the R wave in lead V5 as well as the S wave in V2, then the sum is more than 35. So we can probably diagnose left ventricular hypertrophy. You can also see that like right ventricular hypertrophy, here are also associated ST segment depression and T wave inversion in lateral leads, which is termed as left ventricular strain pattern. In right bundle branch block, the QRS duration is more than 120 milliseconds or 3 small boxes. There is a prominent R wave in V1 and S wave in leads 1 and V6 is more than 40 milliseconds wide. Shown here is the ECG of a patient with right bundle branch block. Here you can see that the QRS width is more than 3 small boxes or more than 120 milliseconds. Here is a prominent R wave in lead V1 and S wave is more than 40 milliseconds in width in lead V6. In left bundle branch block, QRS duration is more than 120 milliseconds or more than 3 small boxes. There is a broad, notched or slurred R wave in leads 1, AVL, V5 or V6. there is a small or absent initial R waves in V1 or V2 that is followed by a deep S wave, and there is absence of septal Q waves in leads 1, V5 and V6. Shown here the ECG of a patient with left bundle branch block. Here you can see prominent broad R waves in lead 1 and V6 as well as broad S wave in lead V1. As far as the fascicular blocks are concerned, left anterior fascicular block is manifested on the ECG by merely left axis deviation. Left posterior fascicular block, although very rare, is reflected on the ECG in the form of right axis deviation, and right bundle branch block usually is not supposed to cause any axis deviation. If a patient with right bundle branch block also has left axis deviation, then it is termed as bifascicular block, and similar is the case if there is right bundle branch block along with right axis deviation. And if bifascicular block is combined with a prolonged PR interval or first degree AV block, it is termed as trifascicular block. So here we conclude